The title of my free paper is the Biomechanical Responses to PRK in High and Low Myopia. It's a comparative analysis, and my co-authors are Dr. Krishna Pujata, Dr. Anubha Rathi, and Dr. Somashila Murthy. So corneal visualization using Scheimpflug technology, or Corvus ST, represents a paradigm shift in leveraging ultra high-speed Scheimpflug technology in order to assess corneal biomechanical responses to a standardized air puff and to measure the deformation of the cornea. While there is a significant amount of literature which has already been published on corneal biomechanics in virgin eyes, especially in those post-LASIK and post-SMILE eyes, there still remains a lacunae in eyes who have undergone PRK surgery. Now, PRK is considered to be biomechanically more stronger than LASIK and SMILE, primarily because of its tissue-sparing nature. However, a significant gap still exists in the understanding of corneal biomechanics in highly myopic eyes. And this was something we attempted to address in our study, which aimed to understand the differences in corneal biomechanics between two specific patient groups. That is, those with high myopia and low myopia following PRK surgery. Our hypothesis was that the inherently poor corneal biomechanical properties in high myopes might result in greater post-surgical changes in this cohort of patients. So it was a retrospective study conducted at the L.V. Prasad Eye Institute. We included all patients above the age of 18 with a stable myopia or myopic astigmatism, and those who had a normal or thin corneal pachymetry, as well as those with a mildly suspicious topography but who would otherwise be suitable for a laser refractive surgery. All the surgeries were performed by a single surgeon on an excimer laser at a frequency of 500 Hertz. MMC was used in a concentration of 0.02% for 10 seconds per diopter of ablation and was thoroughly washed after the procedure. And a standard protocol of postoperative antibiotic, steroids, and lubricants was followed. Prior to the surgery, all patients underwent a routine ocular examination, and topography was performed on the Pentacam HR. We analyzed, amongst other parameters, the apical pachymetry and thinnest pachymetry. This was done pre-operatively and then at 1 month and 3 months after surgery, and the difference was then documented as the delta change. In addition to this, the amount of central ablation on the excimer machine was also documented. So this is the Vinci-Guerra screening report from the Corvus machine, and the parameters which we analyzed over here were the DA ratio, the integrated radius, and the stiffness parameter A1 index. And these were taken pre-operatively and then at 1 and 3 months post-operatively, and the difference was documented as the delta DA ratio, the delta integrated radius, and the delta SPA1. So we analyzed 65 eyes of 33 patients, and the average age of our cohort was around 26 years plus or minus 3 years, with an equitable distribution amongst males and females. There was also a comparable distribution amongst the high and low myopes as seen here. So in high myopes, the correlation between the central ablation and delta SPA1 was found to be weak and insignificant. However, amongst the low myopes, we found a statistically a negative significant decrease in the trend, suggesting that an increase in central ablation was associated with a meaningful decrease in delta SPA1. However, there was no significant difference between the high and low myopes when comparing between these two groups. Similarly, in high myopes, the correlation between central ablation and delta integrated radius was weak and insignificant, suggesting that the occurrence or the trend could have occurred by chance. However, in low myopes, there was a significant positive correlation between central ablation and delta integrated radius, suggesting that greater amounts of central ablation were associated with a meaningful increase in delta integrated radius. However, there was again no significant difference found between the high and low myope groups. In low myopes, an increase in central ablation was found to increase the delta DA ratio in a significant manner. However, this again was not found in the high myope group. So the only parameter from the Corvus which we found significant between the high and low myopes was the delta integrated radius. The other two Corvus parameters, that is the delta SPA1 and the delta DA ratio, were not found to be significantly different for either central ablation, delta thinnest pachy, or delta apex pachy between the high and low myope groups. So our conclusion was that subtle biomechanical differences do exist between high and low myopes, and their corneal response to ablation does follow a relatively predictable pattern, and these reports support the notion that PRK, when performed with appropriate adjuncts such as MMC, can be a safe and effective option for high myopes without significant additional biomechanical risks as compared to those to the surgery done in low myopes. Thank you so much.
So do you rate this as better than any of the femtolasics? In PRK, they were all PRK done.
Correct.
And what was the value of low myopia?
So we
Which
took
had changes, which had more changes?
So in the low myopes, we considered were those with a spherical equivalent of less than 6 diopters, and the high myopes more than spherical equivalent more than -6 diopters. And while we did find a trend towards correlations between a greater amount of central ablation and change in biomechanics in the low myopes, we didn't find significant trends of change in the high myopes. But when we compared the two groups, that is the low myopes with the high myopes, we found that the magnitude of change in one group compared to the magnitude of change in the other group was not statistically significant. So we could not at the end of our study say that there was any significant biomechanical change more in the high myop group than that which we would see in the low myop group. But again, our study number was small because PRK is not routinely done in very high myopes, though in our center we do quite aggressively do PRK in higher dioptric powers. So we thought we would look at this data retrospectively to see what we got out of it.
So this change was statistical only or clinical as well?
No, there was no, we didn't document ectasia in any of the patients. We just wanted to see whether any of them were responding differently to such large amounts of ablation.
What was the upper limit of the myopia?
We
You
didn't
went up
do
to?
anything more than 10 diopters of spherical equivalent.
Thank
Time duration for mitomycin C used for low myos? What was the lowest duration that you used it for? Was there a cutoff value? I saw the 10 seconds per
Correct,
diopter, but
yes.
usually we have.
Yes. No, usually in our center for a diopter, it's surgeon preference. We might not use MMC. This surgeon did use MMC for the purpose of the, for at least for the patients who we were doing Corvus post-op, we ensure that we used MMC in all the cases.
Thank you.